Hello, everyone, and welcome to today's virtual session on menopausal hormone therapy. We are so glad you could join us for this important discussion that is part of the Beyond the Pause series that started early October on different platforms hosted by Kenya Obstetrical and Gynecological Society. However, this is the second one on this platform. Last week, we had a discussion on premature ovarian insufficiency by Dr. Mushiri and Dr. Modoni, who are also with us on the call. We have more topics in this series lined up for you. On 28th of October, we will be discussing abnormal uterine bleeding for women on HRT, and this will be hosted by Kenya Obstetrical and Gynecological Society Central Branch. On 4th of November, we will be discussing breast cancer screening and treatment, as well as risks. This will be hosted on this platform. And on 9th of November, we have an in-person meeting on lived experiences by Women's Reproductive and Midlife Health Network Africa. Then on 11th of November, we're going to discuss the non-hormone HRT. This will be hosted by the Kenya Obstetrical and Gynecological Society Coast Branch. Then we will wind this series on 18th of November, when we will be discussing lifestyle advice for women pre and in menopause. This will be hosted on this platform. My name is Owende Wandai. I'm an obstetrician and gynecologist based at Kenyatta National Hospital. I'm also a minimal access surgeon and head of Department of Obstetrics and Gynecology, Kenyatta National Hospital. I'll be your moderator today, and I'm here to guide the discussion, ensure everything runs smoothly over the next hour and a half. We'll cover menopausal hormone therapy, including what it is, the benefits and risks associated with menopausal hormone therapy. We are also going to talk about alternative treatments and how to make decisions on complex cases. We are fortunate to have with us today Dr. Amanda Kenya, who is a dedicated obstetrician and gynecologist committed to championing best practices in healthcare, supporting cutting-edge medical research, and elevating existing standards of women's health. She has a special interest in menopause, and that's why she's making this presentation today. And she's also passionate about sharing health information on social media. We encourage questions throughout the session. Please feel free to use the question and answer and chat function to submit your questions. We'll address as many questions as we can during the Q&A segment at the tail end of this session. And should you experience any technical issues, please reach out to our support team using the chat feature. They are on the call. So we are all aware that menopause is a natural biological process marking the end of a woman's menstrual cycles, and it typically occurs between the ages 45 and 55, but this can vary. Menopausal hormone therapy, also known as hormone replacement therapy, is used to relieve some of the symptoms of menopause, such as hot flashes, night sweats, vaginal dryness, by supplementing the body with estrogen plus or with progesterone. Understanding menopausal hormone therapy is crucial because it involves weighing the benefits of symptom relief against potential risks. It's a highly individualized decision that should be made in consultation with an obstetrician and gynecologist and other healthcare providers. And so without much further ado, I would like to hand over to Dr. Amanda Kenya to make her presentation. Welcome, Dr. Kenya. Please make your presentation.
Okay. Thank you for the introduction, Dr. Wende. Good afternoon, everyone. I am very excited about today's presentation. This is one of my favorite things to talk about. I'm not able to start my video. Maybe the host can assist, but in the meantime, I'll just go ahead. So today we're going to talk about menopause hormone therapy, practical prescribing. So we're going to go into details about the dosages, and I'm going to show you some pictures of what we have available, so that hopefully by the time we're done with today's presentation, you're actually confident in prescribing. Okay, we're going to first look at the indications and the contraindications of MHT, review the benefits and the risks, understand the different types that we have and the formulations, and know how to assess the patient, although I'll just discuss that briefly because we've already talked about that in a previous presentation. How to individualize therapy, and then practical prescribing, how to start, what dose, how to monitor and follow up, and eventually how to wean off or taper off. So just a brief overview. Dr. Wendy has already done a good job there, and other previous presenters. But menopause is a permanent cessation of menstruation for 12 consecutive months, and it marks the end of reproductive function. Like Dr. Mushiri last week mentioned, that the global average age is about 51 years, but it tends to be a bit lower in Africans and Asians. I've seen a study that was done in Western of this country that quoted an average of 48 years. And then, of course, it's also earlier in smokers and in women who've undergone surgical menopause and women with premature ovarian insufficiency. There are over 100 symptoms, but the most common are vasomotor symptoms. So that's the hot flashes and the night sweats. 75% of women undergoing menopause will experience this, and it can last for 7 to 10 or even 15 years. Then there's vaginal atrophy and urinary symptoms like frequency of recurrent UTIs, which is called the genitourinary syndrome of menopause. It occurs in about 40 to 50% of women and is a cause of morbidity. And then we have mood disorders like depression and anxiety and irritability. And then we also have what we call HSDD, which is hypoactive sex. There long also type 2 diabetes, the risk is increased after menopause. So the benefits of MHT are relieving the vasomotor symptoms, bone health, protecting the bone, improved sleep and mood, genitourinary syndrome of menopause relief, cardiovascular protection, cognitive function and prevention of dementia. It also benefits the skin and hair health. Postmenopausal women often complain of thinning hair and very dry skin and even eczema. Joint pain relief and reduction of the risk of type 2 diabetes. So we all know there are risks. Endometrial cancer, breast cancer, there's a risk of getting a clot in the lung or the limbs, or getting a stroke. There's a risk of gallbladder disease and cardiovascular disease. So even before or while planning to start MHT, you need to counsel a patient on these risks, but it's good to have numbers while you're counseling them. So if you can see this slide, it's just a slide that shows the cases per 1,000 women of breast cancer, endometrial cancer, all these after using MHT for 5 years. And then this is after using MHT for 10 years. So for breast cancer, for example, if they're using combined estrogen and progesterone, you have, if they're using it for 5 years, we have 8 extra cases per 1,000 women who are using combined. And if you look at estrogen only, it's only 3 additional cases. So you see the progesterone is actually increasing the risk. And then if you use the HRT for longer than 5 years, the risk is higher. For endometrial cancer, if you use combined estrogen and progesterone, there's no risk because the progesterone is protective. But if you're using estrogen alone, there's an increased risk if the patient has a uterus, especially if you use it for long. Ovarian cancer has a very minimal risk, whether you're using combined or estrogen only. And then when it comes to VTE, there's an extra 7 of combined for 5 years. And when you're using estrogen only, there's only an extra 2 cases. So it shows that progesterone is actually adding a risk. Of course, the risk increases when you use it for more than 5 years. The same goes for stroke. The risk increases when the risk for when you're using combined is the same as when you're using estrogen only. For cardiovascular disease, there is no extra risk. And for fracture of the femur, we know it's actually protective, so there's no risk. So we can use these numbers to try and counsel our patients about the risk because they're usually quite concerned. So what are the indications? Not every single symptom of menopause will cause you to advise a patient on menopause hormone therapy. So the indications are moderate to severe wastewater symptoms, genitourinary syndrome of menopause, that's vaginal dryness, the atrophy, the recurrent UTIs, and painful intercourse. Osteoporosis prevention, especially in a patient who has a high fracture risk, if her bone DEXA has shown that she's at risk of a fracture, and also if she has a family history of fracture of the femur, especially if the patient is not able to tolerate bisphosphonates. Like we were told last week, when a patient is diagnosed with premature ovarian insufficiency or surgical menopause, they should be started on MHT to prevent all the long-term effects of menopause up to an average age of 51 years. Although these days we see people saying continue to use it until as long as the benefits outweigh the risks. People now are moving away from stopping the drugs after a certain period, they're just continuing them. Then again, the hypoactive sexual desire disorder. So this is not simply low libido. It's low libido that is causing distress to the patient. Because remember, not everyone minds having a low libido. So low libido, which is actually affecting the patient psychologically and causing her distress, then we consider MHT, in which case we would be giving specifically testosterone. So we do have contraindications, which I believe we're all aware of. There are some absolute and relative. So some absolute contraindications include having a history of breast cancer or endometrial cancer, but this does not count for vaginal estrogen. Vaginal estrogen is still safe in those cases, of course, in consultation with a specialist. If the patient has active or recent VTE, if she has uncontrolled hypertension, severe liver disease, and of course, if she's allergic to any of the drugs. And then relative contraindications, which you can work around by consulting a specialist and also considering the different formulations, include having a high cardiovascular risk, migraine with aura, in which case you would consider transdermal formulation, and obesity, in which case you would also consider a transdermal formulation. We'll speak later about the formulations. So the types of menopause hormone therapy are estrogen only, combined estrogen and progesterone, and testosterone. So estrogen-only therapy is usually prescribed for patients who have had a hysterectomy because there's no risk of endometrial cancer. Right now, we are tending to move towards estradiol, which is bioidentical, which means it's the most similar to the endogenous estrogen that our ovaries were producing. we're moving away from prescribing conjugated equine estrogen, such as Premarin, because there's an issue about the ethics of collecting this from horses' urine, and also it does pose a slightly higher risk of VTE. However, it's important to note that Premarin is, or conjugated equine estrogen is the only one that actually has a protective factor on breast cancer. Then combined estrogen and progesterone is prescribed for women with a uterus because the progesterone is protective against endometrial hyperplasia and or cancer. So there are different kinds of progestogens we're giving. Right now, just like with estradiol, we're moving away from the synthetic progestins and we're trying to prescribe micronized progesterone, which is bioidentical. It tends to have a favorable cardiovascular and breast safety profile. So some examples would be Gestaglen, Tasten, Endogest, just anyone where on the box it says micronized progesterone. So some of the synthetic ones, which have a bit of a higher risk of VTE, are medroxyprogesterone acetate, which is Provera, levonorgestrel, and norethisterone, which is Primolut-N. We're trying not to use those anymore, but sometimes we may have to, because micronized progesterone, sometimes patients don't tolerate them so well. It can cause a lot of sedation and bloating and discomfort, especially within the first few weeks. So there's still a room for them. So this progesterone, while you're giving combined estrogen and progestogen, the progesterone can be given either cyclically or continuously. So you use it cyclically, for example, in a patient who is perimenopausal, who is still having a monthly bleeds. So you would take the progesterone for only 12 to 14 days out of the month, and then she would have a bleed towards the end of the month. Or if it's a postmenopausal patient who is not interested at all in bleeding monthly, then we would give her continuous progesterone as well as continuous estrogen, which she would take daily, and she would have no bleeds. So let's talk about the different formulations. I think I'll show you some pictures in the next slide, but there are different formulations and each has its pros and cons. So the first one is oral. I think we're all familiar with the oral formulations that we have. They're affordable and they're easy to find, they're easy to take, but it's possible for patients to forget to take a pill every single night. And also, because of the fast metabolism in the liver, the oral formulation tends to have the highest risk of a clot because it increases the coagulation factors. Then we have patches, which are applied to the skin for a week. So either Monday, Thursday, or Tuesday, Friday, like that. You just remove and replace. It's usually applied below the breast level, so on the abdomen or on the buttock. It's easy to use and it tends to provide a constant level of the hormones. And it's also easy to adjust. So you can use 2 at once, or you can use half or 1.5 if you're really trying to, or even 3/4 if you're trying to just change the dose. And it also has a low VTE risk because there's no fast metabolism. But the con is that, you have to stick something on yourself. Some patients don't like that. It can also leave a plaster mark and cause some irritation on the skin, especially if you keep sticking it in the same area. So we have advised patients to keep changing the location. Also, in high climates, it can lead to higher absorption rates, in hot climates, I mean. And then in some women specifically, it just doesn't absorb well. No matter how high of a dose you go, you realize she's not getting relief. So you end up just testing her hormone levels, like the estrogen level, and you find it's almost zero still. And then you have to change formulation because for that specific patient, she seems not to be absorbing it. Then there's the gel, which is quite easy to use and also to alter the dose. It absorbs well. It can also be used in combination with a patch to top up if she needs a bit of a higher dose. And it can also be used more on certain days if she has certain symptoms. The con is that if you'll need large quantities if she needs a higher dose, and the gel is expensive. and can also be forgotten. The spray, which is also expensive, is a light preparation, and it's also a really small volume, so it's easy to carry around. It's easily absorbed. Can also be used in combination with patches. And yeah, it's expensive. So if she needs a high dose, that means she needs a lot of it, and that might be, more burdensome on her budget. And sometimes the absorption is unreliable. Then implants and injections, the good thing with them is that they are long acting. So they're usually implanted right under the skin. The problem is that, number one, they're expensive, and number two, it's quite difficult to control the dose. So in some women, you find if you test them a few weeks after implanting, the dose of the estrogen will be really, really high, super high levels. And in another person, it will be low or normal. So it's controversial. The use of the implants is quite controversial. And then, of course, there's the vaginal formulations, which are inserted into the vagina. They have minimal systemic absorption, and so that's why they're good for long-term use and also safe for breast cancer survivors and survivors of other gynecological cancers. So here are some pictures of the ones we use. So this is Femostone. I think we're all familiar with Femostone. So there's the Femostone plain, which is a combination of estradiol and dydrogesterone. It's used cyclically. So the white pills are combined estrogen the white pills are estradiol only, so for 2 weeks. And then for the last 2 weeks, she'll be taking a combination of estradiol and dydrogesterone, and she's going to bleed after this last pill. And then there's also a Femostone, whereby there's no difference in pills. They're all the same combination of estradiol and dydrogesterone for postmenopausal women so that they don't get a bleed. Then we have some patches. So some of the patches have estrogen only, and some of them have estrogen plus progesterone. So the ones with estrogen only, the lowest dose is 25, then it can go up to 50, 75, 100. We're going to talk about which dose to start with later. And you keep increasing or reducing the dose based on the side effects and also based on if she's experiencing symptom control. Then we also have patches which have both estrogen and progesterone combined. And then we have Everel C, which has 4 patches of the plain estrogen and 4 patches of the combined estrogen and progesterone. So these patches are usually used twice a week, Monday, Thursday, Tuesday, Friday, like that. So that means for 2 weeks, the patient will use estrogen only, and then the last 2 weeks, she'll be using a combined patch. Okay, then we have gels. You can see the gel on this side. They tend to be a little bit expensive, but you use 2 to 4 pumps per day. You can even start with 1 pump, and there are so many videos on YouTube that you can show the patient, because sometimes the directions on the back on the pamphlet are not so clear. So there are specific videos that I'd like to send patients to understand exactly how to use it, make sure they're not overdosing or underdosing, and also make sure that they are applying it on the correct. They are meant to apply it on the outer arm, not the inner arm, because we don't want it to touch the breast and potentially increase the risk of breast cancer. Or also they can apply it on their inner thighs. So the gel also comes in form of sachets. Then there's testosterone. Unfortunately, like we said earlier, testosterone is only FDA approved for use for low libido in Australia. So they have a special formulation for women. But for us and the rest of the world, we have to kind of use the formulations that were made for men and adjust them and figure out how to use them at an appropriate dose. So we use 1% testosterone gel. It comes in a 2.5 gram sachet, which contains 50 milligrams of testosterone. Now, a man would usually use 1 whole sachet per day, but a woman would use 1/8 of a sachet per day. So she's going to squeeze out a pea-size amount. When she's starting off, she's just going to take a little bit, and by the end of the sachet, it should be around 8 days, 8 to 10 days, which would give her about 5 milligrams per day. So she's going to keep adjusting the amount until she's figured out how to ensure that a sachet is lasting 8 days so that she's not overdosing. So for testosterone, we give it for low libido, but still we give it with estrogen. It works best with estrogen, but we avoid oral estrogen for someone who is on testosterone, because oral estrogen increases the levels of sex hormone binding globulin, which then attaches to the testosterone and makes it not available for use in the body. So here are some sachets of the testosterone. Yeah. So just a quick note about vaginal estrogen. It's safe to give in addition to MHT. So if you're giving oral, or if she's using pumps or gels or patches, it's still safe to give the vaginal estrogen, because most women will need both. The oral and the patches and all that might not really adequately address her genitourinary symptoms well. It comes in form of a pessary or a cream, gel, or vaginal ring. I think the one that we are most familiar with is the cream, Premarin. And then it's long acting. I mean, we give it for long, so you would need to give a patient a prescription for like 6 months so that she doesn't keep coming back for prescription. And then the thing to note about vaginal estrogen is that it's such a tiny dose. If you use vaginal estrogen, which we usually prescribe 1 gram twice a week, that's Monday, Thursday, Tuesday, Friday. If she uses it that way for a whole year, that's equal to 1 milligram of estradiol. That's why it's safe in most cases of patients who even currently have active breast cancer, or who have a recent history of breast cancer, or who have endometrial cancer or cervical cancer or anything. Of course, in consultation with specialists. So there is a lot of evidence showing that there is no increased risk of cancer among women who are currently undergoing treatment for breast cancer, or in those who have personal history who use vaginal estrogen for urogenital symptoms. So we already talked about assessing the patient before MHT in a previous presentation, but just briefly, we know we're meant to take a medical history, discover the patient's symptoms, which of the 100 symptoms she has, and what is the symptom burden, what is her quality of life, has she used hormones before, is she using them correctly, what are her cardiovascular risk factors, and the breast and gynae cancer risk factors, what are her VTE risk factors. And then we need to examine routine pelvic and breast exam, including a mammography, send the patient for bone DEXA, especially if they've reached the age of 55 and or they have a high risk of fracture. And then we do some lab tests. We know we don't really need to do tests to confirm menopause, but if you're suspecting a patient has premature menopause, then it's a good idea to do an FSH. And then remember, when we receive a patient who is complaining of symptoms of menopause, it's a good idea to just do a general checkup. Maybe she hasn't seen the doctor in a while, and also just to get a baseline for monitoring the NHT. So her lipid profile, her liver function test, HbA1c. It's a good chance to do a pap smear, thyroid function. Vitamin D is often low in our population. And then if you intend to start testosterone because the patient complained about low libido, it's a good idea to have a baseline testosterone, or to calculate what we call a free androgen index, whereby you take the total testosterone divided by the sex hormone binding globulin, multiply by 100, and if it's between 2 and 5% or below, then you would consider replacement. So just once again, the roadmap of assessment. First, you assess her criteria. Is she pre or post-menopausal? Are we in the window of opportunity? Remember, the window of opportunity is if she has had, she's been in menopause for 10 years or less, or if she's under the age of 60. That's the perfect age. Not to say that you can't start MHT later, but it's safer and more beneficial for the patient to start it within the window of opportunity. Also ask about the symptom burden. Then we come to rule out the contraindications, evaluate her cardiovascular risk and her breast cancer risk, evaluate VTE risk, find out if she has a uterus or not, so that we know which kind of MHT we're going to give her. Just a quick note on perimenopause, because most of the presentation is about menopause. For perimenopause, we now have the extra need of contraception, right? So some people choose to use COCs. You need to review the contraindications for that based on the MEC wheel, the WHO wheel. COCs are also good for controlling PMS, mastalgia, and irregular bleeding. And we would give her a low dose pill. Most of the pills we have in our country are low dose. If she still wants to have a period every month, then you give her continuous estrogen with cyclical progesterone, which can cause some irregular bleeding. And then also a good idea is to give her continuous estrogen with a Mirena coil, which really sorts out the heavy bleeding that is typical of perimenopause and even eliminates the bleeding, but might still leave room for cyclical symptoms. So another thing about whether to choose COCs or MHT for a patient in perimenopause, it's a little bit controversial and there are different schools of thought. Some women say, or some gynecologists say that if someone is in perimenopause, they still have their own hormones and being produced endogenously. So if you're adding more hormones, it can cause some super high levels that will put her at an increased risk of all the risks of MHT that we talked about. Because once in a while her estrogen is normal or it's high, the hormones are going up and down, up and down. So if you're just adding your own extra hormones, you don't know exactly what might happen. Whereas if you give COCs, you're suppressing the endogenous hormones and you're providing the exogenous ones to give her a steady level. So that's just food for thought. Yeah. So when you're starting MHT, it's good to start low and go slow. So the aim is to use the lowest effective dose. Depending on how severe the patient's symptoms are, some people might say, oh, I'm going to start high and then I'm going to titrate it downwards. So that's also a school of thought, but generally, it's advisable to start low. So you start with the lowest dose and you climb up. And then there's always room for adjusting based on symptom control and side effects. So in terms of which route to choose, we've talked about all the routes, and it's important to just lay out all the options for the patient. Tell her, even when it comes down to cost, how much this will cost you per month, because we also don't want to be switching from one to the other. After you evaluated her, you and her can come to a shared decision of which one she's going to use. So just a little bit of dosing. So this is for estrogen. This is the oral estrogen and the Premarin. This is what we consider a low dose. This is the mid-range doses, and these are high doses, okay? So it's good to know when you're prescribing, am I prescribing a high dose? And if so, for what is the reason? So say, for example, a patient came and she said, oh, I used estradiol and I used a 0.5 milligrams and it was not helpful at all. And now you tell her, or maybe she's obese and now she has some risks that have come up since then. So you want to maybe change the formulation. And maybe you don't want to start on a low dose because it wasn't beneficial to her last time. So maybe you want to start in the middle. So this is how you would jump, so that you know that for oral, for the patch, for the gel, and for the spray, these are the low doses. One pump of the gel is quite a low dose. It's more typical to start with 2 pumps. That's 1 pump on each outer arm. And then there are high doses out as well for specific situations. But as we know, we need to be careful and we need to follow guidelines. Just recently, a prominent menopause specialist in the UK was, sort of punished for prescribing too high doses. There are guidelines, but we follow the International Menopause Society and the Menopause Society. So it's important to keep that in mind. Okay, so I hope you've taken a screenshot of this. Then we have progesterone. So we said if you're prescribing progesterone cyclically, she's going to take it for 12 to 14 days per month. So if it's dydrogesterone, that would be a low dose, 5 milligrams. If it's micronized progesterone like Susten or Gestaglen, it would be 200. This is just for 14 days, 12 to 14 days. If it's Provera, it's 5 milligrams. If it's Primolut-N, it's 1.25 to 2.5, although we don't have that dose in our country, so you just give 5 milligrams. And then if it's continuous progesterone, these again are the doses that you would give for a low dose or for a high dose. But just to note here, for micronized progesterone, you can actually give it up to 300 milligrams. It's usually taken at night. So the thing about micronized progesterone is, I didn't mention it earlier, but you can actually give progesterone alone as MHT. Progesterone alone is known to have benefits on the vasomotor symptoms and insomnia. Insomnia is a huge and very frustrating symptom of menopause, and micronized progesterone has a sedating effect. So it's good for the mood, it's relaxing, and it helps women sleep. So if your patient has said, I don't want hormones at all, I don't want estrogen, the risks are just too high for me, because there's patient preference and values that need to be considered, then talk to her about progesterone alone if one of her main symptoms is insomnia. Yeah, so these are the doses. Then for vaginal symptoms, yeah, we know we prescribe in our setting, it's most likely going to be the cream or the gel. So those are the dosages. So the best thing to do in our setting, we have Premarin. I haven't found any other vaginal cream. So Premarin, they say, start with 2 grams daily for 1 to 2 weeks, and then reduce to 1 gram. But many menopause specialists have just made it easier and said, just give Premarin, just start with 1 gram twice a week. And she doesn't have to stop it. This can be used long term. In fact, some are even saying, advise women aged 40 and above to start using vaginal estrogen, regardless of whether or not they have genitourinary syndrome or menopause, because we know what's going to happen. The atrophy is coming, the recurrent UTIs are coming. And as we get into old age, those recurrent UTIs can actually be fatal. And many times we're busy doing all sorts of microscopy and cultures and trying to figure out what is it that's really causing this patient's symptoms, only to find that once we start vaginal estrogen, her life is changed. Yeah. Yeah, there are also vaginal rings which are available, but not in our setting, not for now, but we hope to change that soon. So monitoring and follow-up. As soon as you've started MHT, advise the patient to come for follow-up after 3 months. You're going to be talking to her about whether or not her symptoms are controlled, what kind of side effects she has, and if they're too bothersome, like breast tenderness, bloating, headaches, and mood swings. Is she actually adhering to the medications? Does she have irregular bleeding? We're going to talk about irregular bleeding in a upcoming presentation like Dr. Awende mentioned, but just to note is that it's common to have some irregular bleeding within the first 6 months. Of course, we'll be adjusting the dose to stop that from happening. But if it's happening after 6 months, then we need to do an endometrial biopsy and figure out what's going on. At that point, a pelvic ultrasound is not sufficient to rule out endometrial cancer. So we'll be adjusting the dose upward or downward and talking to the patient about her expectations. So you can start a patient on a patch or a gel or even Femostone. And, 2 weeks later, she says she has, just a bit of relief, but not much. And she wants you to increase the dose and she says it's not working. So that means you didn't talk about expectations, and now she's hoping for something that is truly not possible. So just allay her fears and assure her that she's going to get relief. And then after 6 months, you can see if you need to increase the dosage or reduce. Another thing is testosterone. Remember, with testosterone, we really don't want to overdose the patient. So after 3 to 6 weeks, we're going to check her levels if we've started her on the gel to make sure we're not overdosing, because we know that there are some side effects of too much testosterone, like acne and oily skin, gaining weight, especially water weight, and thinning hair, male pattern baldness, which can be distressing. And then if it's really high, the levels, then we have a deepening of the voice and clitoromegaly, which are not things a postmenopausal woman wants to deal with. So after the 3 to 6 weeks, after you figure that she's using the correct dosage and you don't need to adjust, then you want to check those hormone levels every 6 months. Another thing about testosterone is many women report not only their libido improving, but they report brain fog going away. She's more active, has some vitality, has a sharper mind, and a better mood. However, still, the guidelines say that low libido or HSPD is the only indication for prescribing testosterone for women. So even though there are those other benefits, we generally only prescribe when there's low libido. And then you're going to be reviewing the patient annually to talk about symptom control, emerging risks, her breast health and doing mammograms, doing a bone DEXA every 5 years, monitoring her endometrium with a pelvic ultrasound. Unless she's bleeding, then you do an endometrial biopsy, and then also follow up on her liver and lipid profile, because we do know that estrogen can increase cholesterol levels. So how long are you going to advise our patient to be on therapy? If we're just following the guidelines, it's typically 3 to 5 years until at least her symptoms are relieved. And then you can start thinking about weaning off as a shared decision with the patient. However, special populations like patients with premature ovarian insufficiency, those who have a high fracture risk, or persistent symptoms, they can continue even beyond 60 years, but you need to monitor them carefully. So different guidelines say different things, which is why at the end of the day, you and your patient really need to sit down and have an honest conversation. Don't try to minimize the risks of MHT while you're speaking to them, but also allay some of the fears they have, which might not be very based in fact. So like the NICE guidelines will say, you give for the shortest duration possible, but the International Menopause Society say it's flexible. You can use you can have an extended use under careful supervision. Many women internationally now are saying, I'm going on MHT and I am not stopping until the end. It makes me feel good, even though I don't have vasomotor symptoms anymore or depression. I just feel better and I feel alive and I want to feel like this forever. So I'm aware of the risks, and for me, the benefits outweigh the risks, and I want to continue. And that's their choice. So now, if you're tapering off or if you're thinking about stopping, unfortunately, you can't just abruptly stop, unless, of course, you have like irregular bleeding or an actual clot or a stroke. If you don't have anything like that, then you want to taper off. So you gradually just reduce the dose by about 50% every 3 months or so until you've managed to stop. So say, for example, if you're taking a tablet of 1 milligram per day, then you want to reduce it to 0.5 milligrams and then eventually stop. Or you can also switch to an every other day dosing before you stop. For a patch, if you're using 50 milligrams, you can use the lower dose for some time before you stop. And as you're reducing this dose of estrogen, you also need to be tapering down the dose of progesterone to prevent hormone imbalances, which can lead to irregular bleeding. This tapering process should not be rushed. It can take 3 to 6 months or even up to a year, depending on the patient's symptoms. And the thing is, her symptoms can also recur or rebound, and sometimes they rebound even worse than when they started. So you need to go back on and take some more time and taper off a bit slower, especially if the patient has been on therapy for a long time or if she has very severe symptoms. So after you've stopped MHT, it doesn't mean now the patient should not be under care. Maybe it might not be your care, but she needs to be on follow-up by a physician annually, just to check her bone density, especially if she was someone who had been found to be osteopenic or have osteoporosis. Also, just to keep monitoring her cardiovascular health and her breast health. The patient should be continuously aware of their risks of osteoporosis and heart disease and cognitive decline, so that they can choose to take maybe some non-hormonal medications to mitigate these risks, even after stopping MHT. But those medications will be, the non-hormonal treatments will be discussed in an upcoming presentation. So some extra resources you can use to figure out how to prescribe is the Australian Menopause Society. There's a practitioner's toolkit, which has great algorithms that you can just follow step by step. It makes it so easy. Also, the Menopause Society and the International Menopause Society. Thank you for your attention. Looking forward to answering your questions. That's where you can find me. I'm happy to send you all the videos I was talking about on YouTube, or that show patients how to use these different drugs. Okay.
Thank you very much, Dr. Amanda Kenya, for that very insightful presentation. We have a number of questions from our participants, but at this point, I'd like to take this opportunity to share a survey tool, which we are requesting our participants to fill out because we value your feedback. Otherwise, I'd like to just kick off the discussion, and I'll start with a few questions that frequently come up. We also have other panelists on this forum, that is Dr. Dorcas Mushiri and Dr. Modoni Gishu, who will also help with the questions. So an example that I'd like you to shed some light on are, what are some common misconceptions about hormone therapy that you encounter? And then number two, just give a brief, please give a brief discussion on, so I know you did mention some, but just discuss briefly some of the factors that might make someone a good candidate for hormone replacement therapy versus those who should avoid HRT. And then thirdly, how do you approach the decision-making process with patients considering HRT? So I'd like you to just respond to those questions, then we can move on to the questions on our Q&A.
Please remind me the first question.
What are some of the misconceptions about hormone replacement therapy that you encounter?
Okay.
And again,
So
Dorcas can chime in. Please go ahead, Dr. Amanda.
Yeah. Okay, so for me, the biggest misconception is that the risk of breast cancer is extremely, extremely high. I think it has been misquantified and misrepresented. And so once you actually just talk to the patient about the actual numbers, you find that their minds open a little bit. Maybe Dorcas can go in a bit more about that.
Yeah, thank you. Before Dorcas, remember the WHI study. You remember the WHI study, and this was a study on effectiveness of hormone replacement therapy for chronic disease prevention in women whose average age was older than 60. So then, as Dr. Dorcas comes in, please also mention the window period that we refer to as far as HRT prescription and use is concerned. Dorcas, please.
Thank you for mentioning that. Right. So we know our window that we spoke about, within 10 years of menopause is the best time, or for the patient to at least be 60 years and below. So above this age, you're increasing the risk of breast cancer and all the other risks that we talked about, even VTE. So the thing about the WHI study is although one of the main takeaways was that MHT causes breast cancer, breast cancer was not even one of the primary outcomes, and the study was not even powered to assess the breast cancer risk. And yet they were testing these hormones in women who are older than the typical age that we tend to start MHT. And number two, they were using estrogen and progesterones that we tend not to use these days. So we're using different estrogens and progesterones. Our patients were starting the hormones earlier. And so the WHI study in terms of breast cancer did not really give us great conclusions. And a few years later, I believe 2 years after the WHI came out, the people who actually did the study came out and said that it's true, our conclusions were not correct, but they didn't publicize that information. They only publicized and put it in the newspapers about how breast cancer is a huge risk of taking MHT.
Yeah, Dorcas?
Yeah, thank you, Dr. Wende and Dr. Amanda. I do agree the WHO study gave us quite a bit of problems. Some of us have been trained in the era that came after the WHI, and we're sort of having to counter a lot of that discussion, and that's part of why we are having this series to sort of educate and inform. Coming to the window of opportunity, we do have evidence at the moment that it's best started within at least 10 years of menopausal symptoms. And I usually say, even if it's the 9th year, we do have benefit for starting menopause hormone replacement therapy. I do want to raise that not all women would require MAHT, and I'm sure Dr. Amanda might have mentioned that. But for those who need it, then it is quite valuable. So that's what we call the window of opportunity. Start it as soon as you can. It means that you need to be diagnosing your women on time. Women need to be aware that they are in menopause or perimenopause so that they can get assessed. So it's quite a bit of work for all of us as clinicians, patients, and anyone who is getting in touch in contact with women. Thank you.
And also just to add that some of the cardiovascular risks associated with menopause actually will go down when you start MHT early.
Yes.
So that's also a consideration.
Yeah.
Yeah, so the second question, Dr. Kenya, I know you did mention some of the factors that we consider before starting MHT. But the question was, what other factors make someone a good candidate for hormone replacement therapy versus those who should avoid it?
Okay, so those who are a good candidates versus those who should avoid it, I think that would come down to comorbidities and the risks. Once you've done the assessment for breast cancer and the cardiovascular risk and the VTE risk, if the risks are high, then you would just advise the patient to opt for non-hormonal treatments for their symptoms, like the SSRIs or the gabapentins and all that. I'm not sure if I've answered your question. I mean the contraindications.
Yes, and of course you did mention the indications for starting MHT. Thank you very much. And how about approaching that decision-making process with patients who are considering MHT? Because we are now starting to see a lot of demand because many women now very active, high up in the professional ladder, and do not want to be bogged down by the symptoms of menopause. Also, these requests are coming fast and furious and would like to make such a rational, individualized decision as far as MHT is concerned. So what would be your take on decision-making process with the patients?
Okay, so for decision-making, let me try and go back to this slide. Because the patient also wants to know that you are hearing them, and you know, even if you're advising against MHT, they want to know why you're saying no or why you're saying yes. So first we start with assessing them and knowing their age. Are they in the window of opportunity? Are their symptoms severe or are they mild, and can they be sorted out with anything else? Although we do know that the most effective treatment for menopause symptoms are menopause hormone therapy. Does she have a significant cardiovascular risk? Now, in this decision making, we would include, other specialists like cardiologists, maybe a breast specialist if she has a risk there. Maybe she has two first-degree family relatives with a history of breast cancer. Maybe she had a clot when she got pregnant 20 years ago. So each of these things step by step, and just assess, agreeing with the patient that, listen, this is a high risk, and we think this might not be a good idea for you, or this is a good idea for you. And you'll find most of the time, more women than not are good candidates for NHT, even if it's a low dose. Yeah.
Oh, thank you for that response. You did mention about non-hormonal treatment, or was it Dr. Dorcas Mushiri? Could you just shed some light on some of the non-hormonal treatments? I know there's a session we have, that will be the second last session in this series. We're going to be discussing the non-hormonal HRT, but just give us a brief on what options do we have for non-hormonal therapies for MHT?
Right. So we do have, like for the vasomotor symptoms, we have options like soy isoflavones, which kind of mimic estrogen once they're metabolized. We have black cohosh. We have turmeric, which is a supplement. We also give magnesium. It's really good for insomnia. For the vasomotor symptoms, we can consider giving some SSRIs like mirtazapine, and trazodone also works really well. And what else? And then, of course, we have the lifestyle modifications, which should be implemented even alongside NHT. Of course, that will be discussed later, but there is a diet that we can advise them on in conjunction with a nutritionist. We do advise them on exercise, and not just the normal exercise for walking for hours, but we actually want them to do resistance training and lifting weights, and to work on their sleep and their mental health. So there's a lot more that can be done other than hormones.
Thank you. I know Dr. Mushiri has her favorite. Is it isoflavones or is it black cohosh? Dr. Mushiri, any comment on the non-hormonal therapies?
Yes, I mean, thank you, Amanda, for raising those. I have found that different women respond differently to different things. So I always like to share the options. And I do have to say sometimes it's actually trial and error. So we haven't quite found evidence that, sort of black cohosh works better than, say, St. John's worts. That said, there are also medical treatments like you've raised, Amanda, in terms of SSRI stuff like gabapentin for the nerves. Tibolone is one that's pretty good as well. And remember that you're giving this based on what the lady has presented with. Vasomotor symptoms, there are new products that are coming into the market. I'm not very sure how soon we would be having them because they're just being tested. And those are some stuff called neurokinase inhibitors that work at the level of the brain, looking quite promising, especially for breast cancer patients who are getting really hot flashes. So they have big names, phenolizetant, and there's another product that's coming into the market. Hopefully that would be able to help us. It's non-hormonal. It's probably going to be the first purely non-hormonal medication for vasomotor symptoms for menopausal women. Yeah, so I do play around with them. Supplements, magnesium, pretty good for sleep. So it's very dependent on what symptoms the lady is.
Oh, thank you very much, ladies. And at this point, I'd like to bring in Dr. Modhoni. We know that cognitive abilities diminish with age. Please just shed more light on whether we do see an improvement of cognition with MHT, or what would you propose that, would to protect women against this diminishing cognitive abilities as they age? Dr. Modoni, please unmute.
Thank you very much. And the thing is, the current conversations and research shows that different things happen again when it comes to different women and how they respond post-menopause. Some of them actually end up getting cognition better than they actually had, or as good as when they were about 20, while others may actually have their cognitive function and ability worsening. And this is also related to the many other things. For example, an accumulation of risk factors for brain health or for cognitive decline throughout the life course. So a case in example, low levels of education. If somebody has had low level of education or has hearing loss from an early age, that will affect cognition with or without menopause. And so post-menopause, this is likely to only get accelerated. So it depends on what level somebody is, and that is why it is important to be able to look at the risk factors for cognitive decline and brain health.
Okay, yeah, that's a good response, Dr. Modoni. Thank you very much. And just before I go into the audience submitted questions, please, and this is to Amanda or Dr. Mushiri or Modoni. What's your comment on the identical hormones? Could you explain? We hear it every day. These identical hormones, what are they, and how do they differ from the traditional hormone therapy?
Dr. Mushiri, you want to take that?
Sorry, I was speaking to myself. So yes, there are different types of hormones and how they are processed and where they have been taken from, basically. So that's the science behind what is bioidentical and what is not. So some things have been removed from, sort of like animals or things that are really close to human beings and play a lot like what is within the body in itself, while some things are processed, i.e. in terms of how they are produced. So that's usually the difference. Now, some people will then have more reactions or more side effects with either one or the other. So I'm not sure if that sort of, I'm trying to make it really simple, like not going into the pharmacokinetics or, the deeper conversations around that. But that's basically depending on where it's been produced, how it's been produced, the processing, and what happens in the body once it's gotten in there.
Thank you, Dr. Mushiri. Yes, we've received a number of questions from our audience. We have tried to answer some online, but just going straight to Eda Bita's question, what are the risks of cancer with hormonal therapy? Dr. Amanda, you might want to probably repeat it, just reiterate some of the discussion points that you have made already. Dr. Amanda. What are the risks of cancer with hormonal therapy?
Right, so we talked about the risks. I don't have the slide open now, but you'll see it in the recording. So there's breast cancer, there's endometrial cancer, and then there's also a small risk of ovarian cancer. And these risks depend on whether you're using estrogen only or estrogen and progesterone. Progesterone tends to add an extra risk of all these cancers, except endometrial cancer, where it's actually protective. And it also depends on how long you're using the MHT for. Is it 5 years or is it more? yeah, so there are risks, and it's good to just have the numbers in front of you when you are counseling a patient and not minimize them.
That's good, Dr. Amanda. But just related to that question, for gel, spray, implant, vaginal formulation, what's their level of risk in regards to VTE?
So in regards to VTE, the oral formulation has the highest risk because of the fast metabolism in the liver. The gels, the sprays, and the patches all have a very, very small risk compared to the oral. And that's why we prefer them for women who are obese or women who have had a history of a clot in the leg or the lungs before. Yeah. So definitely, if you're concerned about VTE, then you would avoid oral.
Maybe I could just add to that, Dr. Wende. I was just in the middle of answering it, actually.
Yes, please feel free.
For those who like numbers, there was a systematic meta-analysis quite recent that's been done analyzing that risk specifically. And if you like numbers, it's nearly a 1.63 relative risk if you're, sort of using the tablets versus the patches. So patches much safer, basically. So to just support what Amanda has said.
And so thank you, ladies. You've mentioned a number of products, Dr. Amanda, Dr. Mushiri. Which of these products that you mentioned today are available or registered in our market in Kenya? What do women have access to?
Yeah. I'm not sure about registered, but I know some are available. So Femostone is available and registered. It's the oral one. And we do have certain pharmacies that import the gels and the sprays and the patches. So they are available. You can reach out to any of us just to find out where you can find them. Once in a while, they might be out of stock, but we've managed to identify some pharmacies that are quite reliable. So the gels, sprays, and patches are available as well as the oral.
Okay, again, related to availability and affordability and sustainability comes a question of costs. So what are the costs like? Because this is a question from one of the participants.
Right. So let's say like a 1 month dose of a gel is going to be about 5,000. If you're using a patch, which is a combination patch, a 1 month dose will be about 18,000. The oral drug, I believe, is I think about 3K per month, the Femostone. Yeah.
Yeah. Okay. Thank you. I know for Dr. Mushiri and some parts of the UK, the testosterone clinics, those are really long clinics. You can spend a whole day seeing women who need their testosterone prescriptions filled up. But just to add onto this, that or maybe you might want to comment whether these are available in government facilities and how do people access these products from government facilities?
Sorry, is that for me, Dr. Wende?
Yeah, for any of the panelists, yeah. But we could start with Dr. Mushiri. You can make your comment.
So far, I'm not aware of any government hospital that's offering them. And it's not, I would presume it's because first, it's not a topic that we've openly talked about in the past. We've got to be able to get to that place where we are seeing the women, we're being able to assess them and then direct them. Then we can be able to start advocating for that, which is part of what this group is currently pushing for. But I'm not aware of any public hospital. We are struggling to get them in private, so I'm not aware. I'm not sure that the private would have them. Or maybe someone else can answer.
Yeah, just to add on to that. So at Kenyatta National Hospital, we did include some of these products in our formulary. So we are hopeful that very soon we should get some of them because we have also just recently started a menopause clinic every Monday morning. So with the demand that will come with it, then we'll probably need to get some of these products. And also, if you look at the essentials medicals list from the Ministry of Health, I think there are some hormones that were included. I know my hospital has been instrumental in coming up with some of the products in the essentials medical list. So that would be also something to look at. But again, we are sensitizing even the prescribers and the users on the use, what is available in the market. And, once people are comfortable, then they will start, prescribing and also, asking for these products. Yeah, so going back to the Q&A from our participants, could you just maybe clarify why you recommended hemoglobin A1C as one of the tests that should be done before initiating MHT? Dr. Amanda?
Yeah, so I had mentioned that we take the opportunity when a patient comes to us to just do a general checkup, assuming she hasn't seen a doctor in a while. We do HbA1c and we do a blood count. We check her urine, her liver, and her kidney function test, just so that we are not treating menopause symptoms while something else is happening in the background. So HbA1c is not specifically or necessarily useful for managing MHT, but I mean for starting MHT, but it's just good to do a full assessment of the patient for completeness.
Thank you. And remember, this period is really a nexus of emotional, physical well-being, and so you must consider this as you see these patients. So going back to our Q&A, Dorothy is asking how we manage low libido in women that is due to family planning. I guess hormonal family planning.
Okay. This question, yeah, does someone else want to take it?
Sorry, what was the question again? Libido.
Yes.
Libido, low
how do
libido
you manage
after
low libido?
family planning.
Yeah, because this is a very common complaint that we know, those of us who administer FP, that the libido is low. But again, it's really a complex presentation. Many times you want to look at other factors. But can you just comment on how we manage that low libido arising from the use of family planning?
So from a personal experiences with patients, the discussion on fast libido as a subject and in itself, and its correlation to using contraception. So what I've found is a lot of times the women, because sometimes they're not getting a period or we've interfered with that, then it goes back to, am I a woman in that perspective? So that's one way I have approached this with some of my patients. They mention and they say, I feel like I'm no longer a woman, or I'm no longer myself. But also remember, women will process, or people generally will process hormones also differently. So whilst you would expect that it won't have an impact, it can have impact in different ways. For example, progesterone only forms of contraception, just like with pregnancy and places where there's high levels of progesterone, it's known to have an impact on mental health. So if the lady is then getting sad or depressed, or there are mood swings related to that, or mood changes, then they may be translating into what she's expressing as low libido. So that's what I tend to do first, is have a discussion on what this low libido is about. I've had women who are very stressed about the thought of the coil, for example, the string knocking on the man. They say that, my husband might feel the string. So they're very shy of, interacting with their partners for that reason. So a lot of times it goes around to a lot of what we are thinking about rather than the actual hormones in themselves. And especially if it's combined, very often I haven't seen that. But yes, I do agree. Libido is a whole subject that it's a big subject as well.
Oh, yeah, it is. I mean, if time allows, then we might even talk about some of the local therapies that are available in the market for treating such complaints. But Dorcas, Michael is asking that he had a client who was 2 months pregnant and claiming to still be using a hormonal treatment unknown to her. She was supposed to bring the medication to see whether it was possible or safe during pregnancy. I guess this probably he's probably referring to some of those herbal pills that some people go into the clinics and they're made to swallow in the clinic, and you never get to see what they look like. There are very many in the market, but what's your comment on this, Dr. Amanda? And probably Dr. Mushiri can add.
Sorry, my internet was unstable.
Yes, so the use of hormone pills. So I was just that probably asking about some of the herbal medications or herbal contraceptives available in the market where you don't really get to see what they look like. The women go into the clinic, swallow them there, and they never get out of the clinic with any pill. Those we see a lot, and a lot of women are on them, and some of them actually get pregnant while on those pills. How safe are these pills? What's your comment? How safe are these pills? Are they registered? Should we still encourage women to take them? What's your comment, Dr. Amanda, Dr. Mushiri?
Yeah, so to keep it simple, these pills and herbal supplements are not safe because we don't know what's in them. We don't know where they come from. We don't know if they've been studied. And we've seen, quite a number of pulmonary embolism specifically coming from these pills. I worked in accident and emergency for 6 years, and I saw quite a number of them. And when you would ask about any supplements or any hormones, that's what they would say that they've been taking, 1 pill once a month. And so you can imagine how high the doses must be if only 1 pill once a month is causing havoc. So I would generally just advise against anything that doesn't have a composition on the back and that doesn't have proper licensing and registration.
Yeah, I do agree with you. I agree with you. And so there's a question on the first neurokinin 3 receptor antagonist that was approved by FDA to treat moderate to severe hot flashes. I think Dr. Mushiri has alluded to this, but probably just shed more light on your thoughts on Veozah or the first neurokinin 3 receptor antagonist approved by FDA.
Yeah, so that's the medication that I'd mentioned before. It's working at the level of the brain, and the theory is that vasomotor symptoms are not skin related, sort of to sweating or the hormones in themselves. It's an instability at the level of the brain where we thermoregulate. So the product is supposed to sit on those receptors and sort of put you back into stability, so to speak. And it was approved, in fact, FDA, I think, might have been 2 or 3 years ago. They've approved for use in the States. It's been approved in Europe last year. The UK is just about to finish their test because the UK likes to test everything. They don't believe anyone else. So, and there's also a new product that I think the study is now called the Highlight study. So the one that was looking at Veozah is called the Oasis, and we've got some good data that's probably going to be coming out next year or so. And then the Highlight study is looking at the equivalent sort of molecule, but being produced, if I'm not wrong, by Pfizer. I can't remember who's the company that's producing it. So we've got lots of positive news from the women, but that's that's not documented. We have to look at the numbers and see whether it's actually useful or not. The advantage is then you're not having women who are really struggling with hot flashes who are not eligible for hormone replacement therapy. So at the moment, I am prescribing for that over the counter because it's not available in the NHS yet.
Oh, thank you very much, Dorcas. And how about smokers and MHT? Does the estrogen formulation matter, or is estrogen totally contraindicated, especially those not willing to quit smoking or are struggling to quit smoking? Is progesterone enough to waylay their symptoms? Is it safe? What are your comments?
So in terms of smokers, I know that there are smokers in Kenya as well, but there's a lot of them here as well. It's not a contraindication. I think I alluded to this in the presentation last week, but for purposes of answering that question, HRT is not a contraindication to a smoker. That said, you're better off giving them patches or the other hormones that are going to bypass the liver. Smokers are at risk anyways of having clots. So you want to encourage smokers to sort of try get off that. I'm sure there are now market products in terms of chewing gums and patches for smokers, and they've got all sorts of things to try and help them. But I've also found having that conversation with the patient may be the actual thing that helps them to stop smoking. So saying, look, there's a risk that you could get clots when I add the HRT. You are struggling with your symptoms, you're having hot flashes, you're not being able to work, you've got bone pains, it has smoking has an impact with the bone density as an independent risk factor. So having those conversations, I found that women have said, really, I was motivated just based on that because my menopause symptoms were so bad. I was really looking for a solution. And if the way out is to stop smoking, then yes, that's it, to at least reduce.
Wow, yeah. Thank you, Dr. Kakuti, for answering that question. And just coming to a close of the Q&A session, I think the others are accolades to the panelists and the presenters. Thank you very much. Please remember to fill out our survey form that has been shared. I think the other questions, we are able to answer them online. So I'd just like, Dr. Modoni, I'll give you the first chance to just give your closing remarks on the use of MHT. Modoni, Dorcas, one minute each, and we finish with Amanda. Then we can close.
For me, it is important that we're able to actually utilize in the maximum way possible the window of opportunity, because again, missed opportunities are almost equivalent to compromised quality of life. So if we are to support women in this space, we need to talk more, let people know what is available, and make the best use of our window of opportunity. And thank you.
Thank you, Modoni. Dorcas?
Thank you so much for having us. As always, I do enjoy this KNH platform quite a bit. And thank you so much for our participants for even engaging, asking questions that are quite relevant. They are helping us curate the whole series. So don't feel that you're just, sort of here to take away without also contributing. You are contributing, and we're really happy and look forward to seeing you in the next one. Thank you.
Thank you. Dr. Mangda, your closing remarks?
Yes, thank you, KNH, for allowing us to use your platform, and thank you to Dr. Wende for organizing and facilitating. Thank you to my seniors, Dr. Mushiri and Dr. Mudoni, for helping me out with the questions. I'm really happy that we're now refocusing on women in midlife, and I hope we can continue to learn more.
Oh, thank you. Thank you very much. Yeah. I'd like to thank our speakers and panelists for sharing their expertise today. And I'd like to thank all of you participants for your thoughtful questions. Some of the resources were provided during the presentation, but for those who are interested in learning more, we'll be having more sessions, as I mentioned earlier, on our COGS platform and also on this platform. Please look out for our flyers. But you can also get more information for the International Menopause Society on issues of menopause and also menopausal hormone therapy. These are recordings of this session that will be available on the KNH website, and we encourage you to reach out to any of us if you have any further questions or feedback. So we hope today's discussion has helped clarify some of the complexity around menopause, menopausal hormone therapy. Thank you all and have a great day. Thank you. You're free to leave.